In case you can't guess, this is part of the ECG approach on rhythm. So as we've talked about in the last lesson, we want to have this really unified approach to our interpretation of our ECGs. The first step, of course, looking at heart rate, and this is going to be talking all about ECG rhythms. So rhythm, most of us are going to be familiar with ECG rhythms. We're going to have seen a lot of them clinically, given that we all have a fairly clinical background. But we want to have a bit of a systemized approach to this to help sort this out. And realistically, we can get a pretty good feel for what the ECG rhythm is by asking ourselves 4 questions. And those questions are, is there a P wave before every QRS complex? Is there a QRS complex after every P wave? Is the QRS narrow or is it wide? And is the QRS rate regular or irregular? And answering those 4 questions can give you a pretty good feeling as to what the rhythm you're looking at is. And we're going to go through some examples here and some review. So the first 2 questions are really looking around the issue of atrioventricular blocks. So is there a problem at the AV node? And that's really what these 2 are going to help you sort out. So is there a P before every QRS? Is there a QRS after every P? And the question around AV blocks, of course, overlaps a bit with the issue of intervals, which we're going to talk about in the next lecture. But having said that, that's super helpful as far as picking out rhythms. Is the QRS narrow or is it wide? So a narrow QRS, meaning a QRS that is under 100 milliseconds, that's a QRS that's originating from basically the regular conduction system, meaning that the beat has come from the atria, passed through the AV node, and gone into the ventricles using the regular His-Purkinje system. So really, a narrow QRS is going to tell us that that whole His-Purkinje system is working pretty darn normal. On the other hand, a wide beat, so particularly if that QRS complex is greater than about 120 milliseconds or 3 little boxes, that's going to be suspicious for beats of a ventricular origin. Now, most of you know that that doesn't hold true all the time, right? We have issues around bundle branch blocks, aberrant conduction, some electrolyte abnormalities, some poisonings, things that will actually widen out our QRS. But anytime you see a wide QRS, you should ask yourself, could this be a ventricular origin beat? And finally, is the QRS regular or are the QRSs irregular? And in particular, this is helpful for atrial fibrillation, where the QRS complexes tend to be irregularly irregular, meaning it's they're fast, they're slow, they're all over the map, and it's certainly helpful for picking that out. So, having said all that, let's go on to a couple examples. So remember those first 2 questions we're going to ask. Is there a P wave before every QRS? And is there a QRS after every P wave? So let's take a moment and look at this rhythm strip. And if you want to pause it for a moment just to have a peek at it, feel free. For most video players, if you press the space bar, it'll pause and restart again with the space bar. Or if not, just pause it on your player. So this is a first degree AV block. So you'll notice there's a P wave followed by a QRS, a P wave followed by a QRS, and every P wave has a QRS after it, every QRS has a P wave before it. And what makes it a first degree block is basically that PR interval, meaning the time between the P wave and the QRS, is elongated. Now we're going to talk about this in intervals, but I bring it up just because we're talking about AV blocks right now. So this is a first degree AV block. So how about this? Let's have a look at the rhythm strip and take a moment to pause and figure out what's going on here. So this is a type 1 second degree AV block. So if you look at the very first QRS complex, very first QRS complex you see on this strip, there's a P wave, a QRS, and a T wave. On the second one, P wave, QRS, T wave. The third one, P, QRS, T. Then there's a P wave and then nothing. Drops a beat. So in this case, what you're seeing is that PR interval is getting longer, and then a beat is being dropped. So this is a type 1 second degree AV block. It's also known as a Mobitz type 1 or a wanky back rhythm. This was really saying that what's happening at the AV node is basically that conduction is getting a little longer, a little longer, a little longer at the AV node, and then it's not conducting. Thankfully, this is not usually a dangerous situation, and things don't progress on to third degree heart blocks. So although we look for reasons why this might be happening, we don't lose a whole lot of sleep about a type 1 second degree AV block. So again, take a moment to pause and let me know what you think about this rhythm. So this is a type 2 second degree AV block. You have a P wave, QRS, P wave, QRS, P wave, QRS, P wave, nothing. And what you notice is the PR interval actually does not change. So it's basically the AV node is conducting normally, conducting normally, conducting normally, doesn't conduct. And this is worrisome because these patients are at risk to go on to complete heart block. So we're going to look for inciting causes, whether there's ischemia, electrolyte abnormalities, etc. And if there's nothing correctable, these patients might actually get a pacemaker. Okay, have a peek at this one. So you bet, this is the third degree AV block. So a couple of things to note here. First one is that if you look at the PR intervals, they're all over the map. It's kind of long, it's kind of medium long, and then it's really short. You're like, that doesn't make any sense. And then you step back and you look at those P waves, and if you measure them out, the distance between the P waves are always equidistant, meaning the atria are just doing its own thing, beating on its own time, and it's not being followed through by the ventricle. The ventricle is beating at its own time, and that's the wide QRS as you see, but they're not in sync. And the things that kind of give this away often is that PR interval is changing all over the place. And if you see that, you should then map out your P waves, which should be basically walking in sync, map out your QRSs, and the ventricles are walking in sync, but the two aren't talking. So this is a third degree heart block, bit of a big problem because people can become quite hemodynamically unstable with this and end up in troubles with asystole. Okay, here's a bit of a tough one. Take a pause and have a look at this and tell me what you think. So the tricky part here is you have a look at it and you have a P, QRS, T wave, P, and then dropped QRS. P, QRS, T, P wave, dropped QRS. So it's certainly not a first degree block, right? Because the PR interval is not long. And it's not a third degree block because the PR interval is not changing. And if you map the P waves out, they're not going to their own beat. So it's a type of second degree block. Could it be a type 1 second degree block? Well, certainly could be. In this case, it has a normal beat, and then there's a lengthening where they drop, normal beat, lengthening where it drops. And because it's a 2-to-1 conduction, that would be reasonable. You don't know. But could it be a type 2 second degree block, again, where you have a beat and then you're dropping one, a beat and then you're dropping one? So unfortunately, in situations where you're dropping a QRS every second time, you actually can't tell if it's a type 1 or type 2 block. So clinically what I would do with this patient is I would run a really long rhythm strip for them and see if you can actually pick up an extra QRS in there or something that'll give you a hint of which of these two it is. If it continues to be a 2-to-1 conduction, you're not going to know. So I would assume that this is a type 2 second degree block, potentially dangerous. You're going to look for correctable causes and be prepared to treat them if they go into third degree block. All right, so we've talked about AV blocks and those two questions, right? Is there a P before every QRS? Is there a QRS after every P wave? Let's go on to the second question, and that is the QRS narrow or is it wide? And remember what we said at the start is if you have a narrow QRS complex, meaning less than 100 milliseconds, then for sure that is being driven by the atria. It's coming down the normal AV node and down the his Purkinje system and working fine. If that QRS is wide, so it's more than 120 milliseconds, you have to wonder if it's from the ventricle. Doesn't mean it's always from the ventricle. Like we said, issues of bundle branch blocks, aberrant conduction, poisonings, electrolyte disorders, those can all widen our QRSs. But anytime you see a wide QRS, stop and think, could this be for the ventricle? So really, if we break them into narrow and wide complexes, we can really think about some different types of rhythms. The narrows, other than the usual sinus beats and the like, we would get junctional rhythms, supraventricular tachycardia, atrial fibrillation, and atrial flutter. Those are the things that we'd hope you'd pick up. And in wide complex beats, we're going to look for ventricular tachycardia, torsade de pointe, and ventricular fibrillation, or the presence of those other things we talked about. So let's have a peek at this and tell me what you think. Right, so the QRS is narrow, which tells us that this is actually a beat that's coming from above the AV node. It's regular, but the only thing that's odd about it is you don't see any P waves. So we would call this a junctional rhythm, meaning that whatever is driving the atria is really right at the AV node or just above the AV node. So you're not seeing any of the regular P waves, you're just seeing a regular QRS complex. All right, take a moment and have a peek at this one. So what we're looking at here is a supraventricular tachycardia, which means that the rhythm that is coming is fast, as you can see there. If you work it out, it's around 150 beats a minute. It's narrow, meaning it's coming from the atria or at least above the AV node, and it's regular, bang on regular. So when I see this, I often think supraventricular tachycardia. And a supraventricular tachycardia just means that there is an electrically reentrant loop, usually around the AV node, where basically a beat goes down, it goes to the ventricles, but then also circles back up into the atria, and then goes back down the AV nodal loop again and drives the ventricle again. So these often end up around 150, 160 beats a minute. They're narrow, complex, and super regular, and that should give this away that this is most likely a supraventricular tachycardia. All right, take a moment and have a peek at this. So you bet this is atrial fibrillation. So narrow complex, meaning that whatever's driving this is coming from the atria. I don't see any P waves in this, and it's irregularly irregular, meaning sometimes it's fast, sometimes it's slow, but the time between the QRS complexes is changing all the time. So this is a dead giveaway for atrial fibrillation. All right, so let's have a peek at this one. So again, when we have a look at this, the QRS complex is narrow, meaning it's coming from the atria or above, and it's fairly regular, although not totally so. So if you have a look at lead 2, particularly the rhythm strip at the very bottom, you'll notice that it's pretty regular, and then all of a sudden there's a bit more space and a little bit less space and a bit more space. So you might think atrial fibrillation, and you wouldn't be wrong. But if you look at the space between the QRS complexes, you'll see these little sawtooth waves. And those waves up and down are the waves of atrial flutter. They're also seen very well in lead V1 if you want to have a peek. But lead 2 is the best one if you look at that rhythm strip. And so what you get is basically a variable conduction at the AV node. And so the QRSs are fairly regular, but occasionally they can be a little longer, a little less. But these sawtooth waves are the real giveaway that this is atrial flutter. All right, so not a great looking cardiogram. So this is ventricular tachycardia. So you have a look at it, the QRS is wide, which makes me think this is potentially ventricular in origin. It's really fast, isn't it? So it's got to be around 250 beats a minute. And it's quite regular. So regular, wide, fast equals ventricular tachycardia. Now, there's some ways you can kind of figure out if there's something else going on, and we're going to probably touch on that a bit in the ECG lectures you have. But realistically, if you see something like this, you should be scared. And my motto is, if you see a rhythm that scares you, you scare it back. And of course, we scare it back best with electricity. So if you see something like this, you're unsure, call it ventricular tachycardia and shock it. I hope they did not sit too long getting this cardiogram, but apparently they did. So what is it? So this is ventricular fibrillation, right? Wide complex QRSs, basically quite irregular all over the map and unorganized. This needs a little jolt of electricity, not a better cardiogram. So we do see this once in a while, also a little worrisome. What is that? So this is torsade de pointe, and so what we see here is a wide complex rhythm that is somewhat regular, but you get this funny look to it where it looks like it gets bigger and then gets smaller and gets bigger and smaller. We call it oscillating axis, basically, which means bigger and smaller, bigger and smaller. This is a type of ventricular tachycardia, so treat it like that if you see it. Patients are likely going to be unstable and might need cardioversion or defibrillation. But having said that, the cause of torsade is most often electrolyte abnormality or some other QT prolonging issue like drugs or ischemia. So you're going to go looking for an underlying cause. But if you see this, initially treat it like VTAC. All right, guys, we've gotten to the end of this lesson. So just a quick review. If you want to try and figure out rhythm, you're going to ask the first two questions. Is there a P before every QRS? Is there a QRS after every P wave? And that's going to really help you figure out if there are atrioventricular blocks. You're going to ask then, is the QRS narrow or wide? A narrow QRS comes from the atria or the AV node and then uses a normal conduction in the ventricles. A wide complex is going to make you wonder about a ventricular beat, but it could be something else. It could be aberrant conduction, could be bundle branch blocks, and we'll get into some of those. But if you see a wide complex beat more than 120 milliseconds or 3 blocks in width, then you should be thinking about ventricular beats. And then finally, you're going to ask whether the rate is regular or irregular, knowing that the irregular rates and irregular QRSs, you're going to be thinking about atrial fibrillation if it is narrow complex, and you're probably going to be thinking about ventricular fibrillation if it's wide and irregular. So that's it on rhythm, guys, and we will see you in the next lesson.